When I wake up in the morning, I never eat food right away. I take the time to kind of get ready. If I take a shower, get dressed, I'll catch up with some emails or whatever it is.
The
I
word fat often triggers a powerful negative emotional response.
A 68-year-old woman named Margaret stands quietly in her kitchen brewing her morning coffee.
I don't belong to the Clean Plate Club. I quit that a long time ago. I don't like food waste, but I'm going to only eat enough to.
A 68-year-old woman named Margaret stands quietly in her kitchen brewing her morning coffee. No warning, no discomfort. Then, without explanation, the ceramic mug slides from her fingers. Her left arm refuses to cooperate. She attempts to call out to her husband, but the syllables tumble out in mangled fragments. One side of her face begins to collapse into a subtle, unmistakable droop. She is experiencing a stroke. Yet here is the detail that remains largely unspoken. Before the sirens even became audible from down the block, Margaret performed an act so unexpectedly simple, so deeply contrary to conventional instinct, that the emergency room physician later admitted to her family it almost certainly spared her from permanent neurological destruction. She did not reach for medication. She made no attempt at resuscitation. She refused to spiral into chaos. Instead, she repositioned her body and orchestrated her breathing in a deliberate, sequenced manner. What Margaret recognized, and what virtually no one has ever been taught, is that the human organism contains a latent emergency response mechanism. When engaged correctly, it can preserve cerebral blood flow during moments when time compresses into its most lethal form. Over the next several minutes, I am going to walk you through precisely what she did, because here is a truth we seldom confront. Every 40 seconds, an American citizen experiences a stroke. Yet what is almost never emphasized is this: the initial 180 seconds, before the ambulance doors open, before the hospital intake, before pharmaceutical intervention or diagnostic imaging, often determine whether a human being recovers full function or faces permanent life-altering impairment. Those earliest moments wield infinitely more influence than most individuals comprehend. Today I'm going to unpack two urgent components that every person beyond the age of 60 must internalize. First, the premonitory signals your neurological system transmits in the fleeting interval before a stroke fully manifests. Second, the empirically supported postural and respiratory protocol shown to help sustain cerebral perfusion while awaiting emergency intervention. This is not hearsay. This is not wellness folklore harvested from the internet. This material emerges from contemporary advancements in neurology and cardiovascular science, and it is accessible to anyone willing to absorb it in the next few minutes. But before we dissect the method itself, you must grasp the physiological events unfolding inside your skull during a cerebrovascular event. The popular imagination frames a stroke as a sudden collapse, an instantaneous blackout, an abrupt biological ambush. That representation is inaccurate. More commonly, a stroke initiates softly, incrementally, almost courteously. Envision your brain as a sprawling metropolis after nightfall. Millions of illuminated windows, each one animated by uninterrupted electrical current. Every reflection, every recollection, every muscular contraction depends on blood-faring oxygen through exquisitely narrow passageways. Now imagine that a single conduit becomes obstructed for mere heartbeats. A modest district of that city loses illumination. Occasionally, the lights flicker back to life. Physicians label this event a transient ischemic attack, or TIA. Frequently minimized as a minor stroke, there is in truth nothing minor about it. A TIA constitutes your brain pulling the emergency lever, broadcasting an urgent bulletin that a major neurological assault may be imminent. And this is precisely where the genuine peril resides. The overwhelming majority of older adults disregard these indicators. An arm inexplicably assumes unusual heaviness. A foot drags without identifiable cause. Vocabulary momentarily evaporates mid-thought. Equilibrium feels skewed, then resets without explanation. The manifestations dissolve, so individuals dismiss them. Internally, however, the cerebral countdown has already initiated. They rationalize that it signified nothing, merely exhaustion, perhaps arising too swiftly. Those were not arbitrary malfunctions. Those were authentic distress transmissions from an oxygen-deprived brain. The occluding thrombus may have originated in the cervical region within the cardiac chambers or migrated upward from atherosclerotic lower extremity vessels. Upon reaching cerebral tissue and disrupting oxygenation, neuronal populations begin perishing within minutes. Here is the indispensable insight that virtually nobody receives. During the inaugural moments prior to complete vascular occlusion, a slender temporal aperture remains during which the organism can still mount compensatory responses. Hemodynamic collapse has not yet fully materialized. That aperture is precisely where this circulatory stabilization technique becomes genuinely life-preserving. Consequently, what are the sentinel warnings you must never trivialize? Abrupt numbness or motor weakness involving a unilateral limb, difficulty articulating language or comprehending ordinary conversational phrases, a face that asymmetrically sags as though one hemisphere has ceased communication, visual clouding or total blindness affecting one or both eyes, sudden disequilibrium or coordination failure, an explosive cephalgic event, thunderclap in nature without identifiable precipitant. Yet here is the phenomenon that ambushes the unwary. These manifestations can persist for as little as 60 seconds and subsequently evaporate completely. And upon their disappearance, individuals exhale with relief. They persuade themselves they have escaped jeopardy. They have not. When symptoms regress, this does not signify the threat has retreated. It signifies the cerebral timer has been activated. This explains why countless seniors postpone intervention even when evidence materializes directly before them. Many older adults were socialized in an era that discouraged requesting assistance unless circumstances were utterly catastrophic. You endured discomfort without complaint. You refrained from theatrical displays. Consequently, when the facial musculature momentarily slackens or verbal output emerges garbled, they self-soothe that the episode will subside independently. They dread inconveniencing others. That silent stoicism, that reflexive endurance, can prove fatal during a cerebrovascular event because the margin between immediate mobilization and a delay of mere minutes can separate complete restitution from permanent cerebral devastation. Another complicating variable involves distinguishing normative senescence from emergent pathology. Experiencing lightheadedness upon rapid positional change that is frequently benign. Orthostatic hypotension, yes. Abrupt vertigo while seated motionless, that occupies a separate category. That signifies danger. Misplacing your automobile keys, unremarkable. Suddenly losing the capacity to construct grammatically coherent statements, that constitutes a medical emergency. The demarcation may be nuanced, yet comprehending that nuance can rescue existence. Now we advance to the protocol itself. This represents the intervention Margaret employed. This is the intervention that may preserve your future. And this is the intervention contemporary investigation demonstrates can produce extraordinary physiological dividends. It is designated the gravity-assisted cerebral perfusion positioning method. The foundational physiology is remarkably straightforward, yet profoundly consequential. When cerebral blood supply becomes jeopardized, gravitational force and intentional respiratory modulation can metamorphose into your most formidable instruments. Throughout a suspected stroke, each second bears disproportionate weight. One of the most expeditious mechanisms to safeguard neurological tissue involves facilitating the heart's capacity to propel blood superiorly with enhanced efficiency. Here is the sequential protocol to implement the instant those prodromal indicators surface. First, resist the urge to panic. This instruction appears elementary, yet it is non-negotiable. Fear-induced catecholamine release constricts vascular diameter and deprives cerebral tissue of oxygenation. The moment you identify manifestations such as abrupt disequilibrium, unilateral limb lethargy, articulatory deterioration, or facial asymmetry, your initial priority is postural security. Assume a seated posture immediately. If recumbent positioning is achievable, preventing traumatic injury from falling is paramount. Whenever circumstances permit, recline completely supine, floor surface or mattress. Subsequently, elevate your lower extremities approximately 12 inches. Cushions, sofa bolsters, even a chair seat will suffice. This singular postural adjustment permits venous return pooled within the legs to re-enter the thoracic cavity and subsequently advance cephalad towards cerebral circulation. You are consciously recruiting gravitational force as an instrument, rerouting hemodynamic flow toward the anatomical region experiencing critical deprivation. However, postural repositioning alone remains insufficient. This is where respiratory manipulation assumes determinative significance. You now initiate unhurried, disciplined, cyclical ventilation. Inspire gently via nasal passages for a 4-second count. Retain that pulmonary expansion for 2 seconds. Subsequently, exhale gradually through oral passage for 6 seconds. This respiratory architecture is deliberately calibrated. Primarily, it elevates the oxygen fraction within your circulatory stream. Secondarily, it pacifies autonomic arousal and stabilizes hemodynamic parameters. Both objectives are indispensable during an evolving cerebrovascular insult. What is genuinely extraordinary is that this dyadic intervention, lower limb elevation synchronized with measured respiration, can assist in preserving cerebral perfusion, sustaining oxygenated circulatory delivery sufficiently for professional emergency responders to assume management. During 2022, investigative findings published in the Journal of Emergency Neurology scrutinized subjects who implemented this precise methodology during transient ischemic episodes. The outcomes were compelling. These individuals demonstrated superior recovery trajectories and substantially attenuated indices of permanent neuronal injury compared to counterparts who remained passive. This represents no curative claim. It does not supplant definitive emergency intervention, yet it purchases something irreplaceable: time. And within the discipline of stroke medicine, temporal currency constitutes everything. The differential between minutes of ischemic insult and months of rehabilitative labor. Now transport yourself into that scenario. You are terrified, cognitively disorganized. Your physical form refuses customary compliance. Within that overwhelming moment, possessing a lucid, deliberate action sequence restores an element of agency. And this psychological restoration carries more weight than most appreciate, because panic is physiologically destructive. Panic engenders shallow, accelerated ventilation. Panic actively depletes cerebral oxygenation. Panic amplifies each pathological variable. Tranquil, intentional respiration accomplishes the antithesis. It conserves oxygen tension. It sustains cognitive clarity. It enables sufficient executive function to summon assistance, document symptom initiation timing, and maintain motionless composure until transport arrives. Consequently, permit me to articulate this without ambiguity. If you or someone within your circle of care detects those prodromal signatures, the objective is not to ambulate through the episode, not to evaluate your resilience, not to wait for spontaneous resolution. The objective is to assume horizontal orientation, elevate the lower extremities, discipline the respiratory rhythm, and permit gravitational mechanics to function on your behalf. Uncomplicated maneuvers, no pharmacology, no apparatus. Actions capable of preserving cerebral integrity during the interval preceding professional medical assumption of care. I wish now to redirect our attention toward a dimension that instills authentic optimism, the neurological system's intrinsic capacity for self-repair, even following significant cerebrovascular insult. I have observed individuals retrieve expressive language, motor coordination, even mnemonic function months subsequent to a stroke whose initial radiographic appearance suggested irreversible devastation. How does this phenomenon manifest? The mechanism is designated neuroplasticity. Your brain does not function as an immutable apparatus. It operates as a dynamic, perpetually reconfiguring matrix. When ischemic injury compromises one neural thoroughfare, the cerebral architecture does not passively capitulate. Alternative pathways progressively assume responsibility for forfeited operations. Conceptualize this as an urban transportation network. Should a primary expressway become obstructed, vehicular flow does not permanently cease. It undergoes rerouting. Secondary arteries assume primary functional burden. Through sustained repetition, those alternative conduits harden into permanence. Your neurological apparatus functions identically. However, here is the subtle yet decisive distinction most individuals fail to apprehend. That architectural remodeling commences early. The initial 48 hours subsequent to stroke represent a period of extraordinary vulnerability, yet the therapeutic activities undertaken during the ensuing weeks and months prove equally determinative. Deliberate mobilization, guided ventilatory practice, targeted nutritive support, each transmits unambiguous biochemical instructions to the recovering brain. Reestablish connectivity, adapt, regenerate. Contemporary investigation originating from academic neurological centers throughout the United States and Japan has illuminated something genuinely exceptional. Geriatric individuals who participate in gradual, rhythmic kinetic activity, even elementary seated calisthenics, demonstrate twice the probability of restoring equilibrium and mnemonic capacity compared to counterparts who maintain post-stroke physical quiescence. Twice. And here is what I find profoundly heartening. Convalescence does not mandate costly instrumentation or exclusive rehabilitative institutes. It can originate domestically, seated in an ordinary chair, animated by focused intentionality. Incremental, purposeful actions carry meaningful weight. When you gradually articulate your digits, when you execute a conscious respiratory cycle, when you simply mentally rehearse motor sequences, you are transmitting instructions to your neurological infrastructure. Restore that circuitry. Consistency constitutes the operational catalyst. Several concentrated minutes each 24-hour cycle substantially outperforms intermittent, protracted therapeutic sessions that lack regular reinforcement. Nutritional biochemistry assumes equally substantial responsibility, both for post-stroke recuperation and primary prophylaxis against recurrence. Beyond the seventh decade, dietary selection directly influences hemorheological characteristics and cerebral metabolic efficiency. Nutritional constituents abundant in omega-3, polyunsaturated fatty acids, antioxidant phytochemicals, and organic nitrates facilitate streamlined vascular transit. Fatty piscine species, chlorophalaceous foliage, root tubers such as beets, pigmented berries, even restrained quantities of dark cacao preparations. During 2023, an expansive Harvard epidemiological investigation documented that geriatric individuals adhering to Mediterranean dietary architecture experienced a 30% relative risk reduction for recurrent stroke across a 5-year observation interval. That transcends modest enhancement. That signifies a fundamentally divergent prognostic trajectory. Convalescence is not exclusively defined by clinical therapeutic engagements. It is codified by how you nourish your biological substrate, the profundity of your restorative sleep, and the gentleness yet persistence of your movement practices. This realization fundamentally restructures our conceptualization of achievable outcomes. No temporal threshold precludes reconstruction. No age prohibits retraining your physiological responses to accelerate, recuperate more intelligently, and shield your subsequent years. Recuperation is not mysticism. It is not stochastic fortune. It is applied biology directed by patience and iterative purposeful action. Let us now redirect emphasis from post-event remediation to antecedent prophylaxis. For those among my audience who have never sustained a cerebrovascular event, the authentic inquiry becomes this: which quotidian behavioral patterns confer enduring cerebral protection established years before imminent danger emerges? The response condenses to a single lexical item: perfusion. When hemodynamic flow proceeds without impedance, the neurological apparatus flourishes. When circulatory kinetics become lethargic or obstructed, subclinical injury accumulates silently, often for years before clinical manifestations become detectable. The most efficacious behavioral intervention I advocate is designated morning circulatory activation, initiating hemodynamic momentum within moments of emergence from sleep. Here is an uncomplicated 3-minute diurnal reset capable of generating quantifiable physiological improvement. Immediately upon awakening, before assuming vertical posture, seat yourself at the bedside margin. Execute 3 prolonged, deliberate ventilatory cycles, completely distending pulmonary parenchyma, thereby saturating your erythrocytes with molecular oxygen. Subsequently, initiate rhythmic contraction of the triceps surae musculature by sequentially elevating calcaneus and digits in consistent alternation for approximately 60 seconds. This activates the soleus complex, occasionally characterized as the corporeal auxiliary cardiac pump, due to its capacity to propel venous blood superiorly from the lower extremities toward the cardiothoracic compartment and ultimately cerebral circulation. Next, execute unhurried circumduction of the scapular and cervical articulations, unforced, as though gradually acclimatizing your physique to diurnal activity. These kinetic sequences appear almost excessively rudimentary to merit serious consideration, yet empirical investigation demonstrates that geriatric cohorts performing low-intensity movement immediately following sleep onset reduce matutinal hypertensive excursions and enhance cerebral perfusion by approximately 20%. No specialized apparatus, no fitness facility, no musculoskeletal strain, only conscious embodiment and rhythmic mobility. Your neurological apparatus responds favorably to periodicity, soleal activation, deep ventilatory exchange, unhurried articular mobilization. Each transmits afferent signals instructing your cardiovascular apparatus to deliver oxygenated hemoglobin to priority territories. When you synchronize this practice with hydration, ingesting aqueous fluid before your initial caffeine dose, you furnish your circulation with the optimal diurnal commencement. A longitudinal Japanese investigation monitored geriatric participants across a half-decade interval and determined that those who consistently executed abbreviated matutinal circulatory sequences achieved superior mnemometric performance relative to non-practicing controls. This is not coincidental. Extended functional longevity and cognitive acuity are not manufactured within acute care facilities. They are constructed through quotidian ritual, incremental repetitions distributed across decades. And the imperative extends beyond ambulation. Sleep architectural integrity carries consequence. Emotional equanimity carries consequence. Stress modulation carries consequence. Persistent adrenergic activation constricts vascular lumens. Conversely, mirth, appreciation, and affiliative interaction produce opposing physiological effects. They facilitate vasorelaxation and luminal expansion. Even modest gratifications, ambulation beneath solar radiation, auditory engagement with personally meaningful musical selections, temporal investment in companions who evoke tranquility, upregulate nitric oxide bioavailability, a molecular mediator preserving arterial compliance and responsiveness. And vascular compliance constitutes precisely what cerebral tissue depends upon for sustained protection. This reframes our conceptualization of therapeutic intervention, not a resource retrieved exclusively during pathological states, but rather integrated seamlessly into daily existence, practiced silently, persistently, without apprehension. The formula for a stroke-resistant neurological apparatus is not flawless execution, it is cumulative reiteration. When you consistently furnish your cerebral tissue with refreshed circulatory delivery, uninterrupted oxygenation, and effective tranquility, you accomplish more than cerebrovascular risk attenuation. You enhance attentional focus, you stabilize effective regulation, you decelerate the senescence cascade itself. Let us revisit the narrative through which we commenced Margaret's lived experience. When her symptomatology materialized that morning, she did not enter dissociative paralysis. She declined panic. She retrieved previously internalized instruction. She assumed seated posture. She reclined to horizontal. She elevated her lower extremities upon a cushion. She initiated gradual, disciplined respiratory rhythm, tranquil, purposeful, as her spouse contacted emergency services. By the moment professional responders crossed her threshold, her expressive language faculties had already commenced restoration. Subsequently, the emergency department attending communicated to her relatives that her anticipatory conduct almost certainly averted irreversible cerebral injury. That constitutes the transformative potential of preparedness. Knowledge transmutes immobilizing dread into actionable intention. Purposeful intention preserves neuronal viability. And this is the assertion I wish to render unequivocally unambiguous. This discourse is not intended to cultivate pathological apprehension regarding cerebrovascular events. It is intended to cultivate operational readiness. Readiness confers autonomy. Readiness furnishes your kinship network with psychological tranquility. Readiness ensures that should the temporal intersection ever materialize, you will not occupy a position of powerlessness. Biological senescence does not mandate inexorable functional decrement. It mandates elevated conscious awareness. You can enhance circulatory efficiency, condition reflexive responsiveness, nourish cerebral tissue through every respiratory cycle, every ambulatory step, every nutritional selection. Therefore, retain this singular lucid directive you can access should temporal compression ever assume determinative significance. When hemodynamic flow falters, resist panic. Assume recumbent posture. Elevate your lower extremities. Ventilate with deliberate slowness. Permit gravitational mechanics to collaborate with your physiology. Uncomplicated, lucid, potentially life-preserving, because optimal health outcomes do not materialize from evading every existential challenge that circumstance may introduce. They materialize from precise comprehension regarding appropriate responsive action when such challenges inevitably manifest. That constitutes authentic personal agency. If you are receiving this message at this moment, disseminate this knowledge throughout your network of concern, a progenitor, an associate, a proximate resident, because the subsequent existence this information preserves may represent someone integral to your emotional landscape. Rehearse this protocol. Enact cognitive simulation. Recline. Elevate the lower extremities. Inspire through 4 counts. Retain for 2. Release through 6 counts. Engrave this sequence into procedural memory, because during genuine emergency, cognitive deliberation is an unaffordable luxury. Only conditioned response remains accessible, and when you have rehearsed sufficiently, your conditioned response will orient toward accuracy. Sustain composure, sustain conscious presence. Your physiological apparatus invariably furnishes you with opportunity for physiological countermeasure. You require only the knowledge to cooperate with it.